Hi, everyone. Welcome back to IVF Parent. My name is Stephanie Caballero, and this is a space where we share real stories. You get to meet real people working in this field because I want your journey as safe as possible, right? So I'm so honored to introduce Dr. David Smotrich. I have known him since I've been in this business for 20 years. He is a highly respected fertility specialist at La Jolla IVF Center, which is one of the leading IVF clinics in the United States. And he brings such skill and such a personal touch to the process for everyone. So whether you're an intended parent, a donor, or a surrogate, you will get the care and consideration that you're looking for. So we're going to discuss today what truly makes a successful IVF journey, choosing the right clinic, understanding the latest technologies, and what you should expect when you start the process. And we'll also dive into one of the most important topics, how to make fertility treatments safer and tailored to each patient. So if you're currently exploring IVF, considering egg donation, surrogacy, or you just want to feel more informed and empowered, this episode is for you. Welcome to IVF Parent. I want David to introduce himself, tell him a bit about himself, and then we're going to talk about what makes David and his team so good and so special. So David, tell us a little bit about yourself.
First of all, thank you, Stephanie, for including me on your podcast.
You're welcome.
I've been very fortunate to be in San Diego for the past 30 years and in private practice alone for the past 28 years. I'm the founder, medical director of La Jolla IVF. I've done over 10,000 IVF cycles, over 8,500 surrogate cycles, over 6,500 egg donor cycles. Been very fortunate to work with you together on many beautiful cases for over 20 years. And I still love what I do, and I still am very passionate about what we do. So it's a great honor and pleasure to be here with you to be able to kind of discuss what our role is.
I remember one of the first times I met you, you said, and obviously with permission of the surrogate, you said, would you like to, come in and see an embryo transfer? And obviously I'd had my own, which were so different because very stressful. I had this very long journey, couldn't get pregnant. And I remember you prayed over her uterus. I mean, you asked permission, but I thought that was such a beautiful moment to watch the little light of the embryo. Yes.
So I still do that. And I was born and raised in Los Angeles of Jewish descent from a relatively religious family. And we don't understand everything. And even though I've done this 30 years, we're blessed with many cases that are successful. And we have struggles with patients that don't have success. And so at that very moment, when everything we've done, everything either the intended mom has done, the surrogate has done, comes to that moment of the placement of the embryo, which in all of the things we do is actually more stressful for me than pretty much anything else I do. But it is because you really need to make sure you're going exactly where you need to go and make sure you don't have any bleeding or anything that would irritate the uterine environment to prevent the implantation. I've done over 10,000 of them. I feel relatively confident with my transfers. We do them under ultrasound guidance so we can clearly see where they go. But at that moment, it now becomes in God's hands. And so I felt that it was most appropriate to ask for help at that very moment, because that's when it's out of our hands. The surrogate plays a major role. The intended woman or parent who is having the transfer into herself plays a major role, but it never hurts to ask for help. So I felt that was the appropriate way. So I learned the prayer both in Hebrew and in English.
Okay.
I say Baruch atah Adonai Eloheinu melech haolam purvu uvu mulei et haaretz. It's chapter 1, verse 28 of Genesis, and God said, be fruitful and multiply. So it's the first commandment in our Bible from God to man, and what they want us to do, be fruitful and multiply. So I felt it was the appropriate prayer at the appropriate time, and very, very early in my practice when I was very young, not 10, but probably closer to 32, that's when I started that prayer. And I would say 99+% of people say, please. There's an occasional person that doesn't want, and that's fine. It's up to them, and I don't do it. But all ethnicities and many people who've had struggled before and finally have success truly believe it's only the prayer that helped. So, and I'm not questioning that, but I really have strong beliefs that you have to have a thought process that you have to be positive that this is going to work. And the confidence is very, very important in the person who's caring. Confidence in the team that's involved is very important. I don't mean cocky and overconfident, but, we've done everything we possibly can to this moment to try and maximize this person's chance or this team's chance for success. Doesn't hurt to ask for a little help.
I'm with you. And, even though it really frustrated me when I was going through IVF, the fight or flight, could have been one of the reasons why I didn't get pregnant. I actually think it's just because I don't suppress, like my immune system doesn't suppress. So my body just attacks the embryo because it just never grew. Like the couple times I would get a heartbeat, it'd be half the size. They'd go, oh, and then, because it just was not the same size. So yeah, you're right. But I have to tell you, when I am talking with my intended parent clients, I'm like, listen, your surrogate gets pregnant when she drinks water. She probably has gotten pregnant when she's on birth control. Please do not talk about your struggles. She is going into that transfer. When those embryos go inside her embryo, she is pregnant. Like, and
I
chances
want to
are
use two
she is.
examples in my own practice, if I may.
Yeah.
I have two patients now with children through surrogacy who are both from Europe. Both were from prominent families who had done, multiple procedures in their own country, then reached an age where they needed an egg donor, moved to a different country in Europe to do egg donor. There's nothing wrong with me, nothing wrong with me. I've seen all the professors. Then they go to the big centers in New York, do egg donation there. It doesn't work. There's nothing wrong. And then they wind up calling me, generally from a referral by you or a different agency or somebody heard through word of mouth. And so many patients in Europe have had, significant number of procedures.
Yeah.
And I'm not saying that the centers in Europe are bad. They're not. It's just they don't have access to the same things that we have in the US. So when a woman calls me and says, there's nothing wrong with me, but I failed 18 transfers, I'm sorry, there's something wrong with you. We don't know what it is, but
Correct.
I will guarantee you that I can put you on the same medication protocol with the same subset of embryos and do it with a surrogate. And when we go to the transfer, all the surrogate is thinking about is, I'm going to get pregnant. I'm so excited to be pregnant and help this family. And she's thinking about, what is this schmucky doctor who's doing transfer number 19 going to be different than all the other 18 guy professors that I saw previously?
Yeah.
And I think the mindset is really very important. And I agree with you. The surrogates come in, they expect to be pregnant. And fortunately, they do very, very well. Now, there may be something in their uterine environment that we're unable to diagnose yet, but it is clear that a woman who has been successful in carrying will have a higher implantation rate and therefore a higher success rate than a woman who's never been pregnant before.
Yep.
And that's actually one of our criteria in selecting a surrogate, unless it's a unique situation where it's a family member who's never been pregnant and everybody understands that implantation may be lower. But for the most part, greater than 95% of the surrogate cases I have done have been women who have had no problems getting pregnant before, no issues during pregnancy, and come in and expect to be pregnant.
They
And
do.
that's a whole different, and you live through this, it's a whole different mindset that a woman says, okay, what's so new about this one that, the other 17 that didn't work is going to
Right.
suddenly work. So I think that, again, I feel badly for patients who've gone through those kinds of histories. And there are many, because I've taken care of quite a few.
Yeah.
Sometimes they're living in countries where surrogacy is illegal or not available. And
Yeah.
so it's illegal for the doctor to say anything about surrogacy. He or she is fearful for losing their license. I think that, with things like podcasts like this, with education that is more available now on the internet. I mean, I started practice on my own 28 years ago. There was no internet. I mean, I tell patients,
Remember that?
they have an app for everything now. I mean, I trained before there were computers, before there were cell phones.
Right.
I mean, we still had beepers, and that was the way, you got called on a beeper, and then you
Oh, I
called a
remember that.
patient
I
on
had
a
a beeper
landline.
too. I did too. I wasn't a doctor though, but that was super cool. I do remember I had email when my surrogate was pregnant, but she didn't. She worked for the county in Oregon. And so she would mail me ultrasound pictures and we would
Right.
talk on the phone every Sunday.
Snail mail.
Yes. Snail mail.
Exactly. So, now if you don't have a response by somebody in a 30-second period, there's something wrong. But,
Yeah, it's pretty
no,
quick.
technology has enhanced a lot of things that we do, obviously, and allows us to do something like this, to be able to have a conversation about what people go
Right?
through.
So it's a
Um,
good thing in some ways,
I,
but you're
I,
right. The speed is,
there,
yeah.
a lot of, but things, so you ask about changes and things like that. I mean, clearly, when I was a resident and a fellow, we only knew how to grow embryos to day 2. And when I was a resident and a fellow, they didn't have ICSI. So a lot of times you had failed fertilization for male factor or poor quality eggs,
Yeah.
and then it was a huge thing to when they suddenly changed from growing an embryo from day 2 to day 3. Now if a patient has an embryo that's, not a day 5 double A grade embryo, they're, livid. How did that happen? And I'm like, you have no idea what we've been able to accomplish.
Right. I was in the day 3, no PGD, like PGD, like there was no testing. There was day 3. Oh, they looked pretty and put them in.
Right, right.
Yeah,
And at that time, we were doing a lot more fresh embryo transfers,
all
not thinking
fresh.
about, is there a disruption in the uterine environment when there's a high peak of hormones at the time of egg retrieval. And when you release the eggs to get the eggs out, the the cumulus cells that secrete estrogen come down, and that swing in hormones could disrupt the uterine environment. So, if it's an intended
Oh,
mom who's getting eggs out and then transferring back into herself, they had lower implantation rates just because of that. And that's why many centers don't do fresh transfers anymore.
no, they do not. And I have to tell you, going through the fresh transfer was rough because it was 3 days after the egg retrieval. My
Anesthesia, and you're bloated and uncomfortable, and
ovaries, yep. I was bloated, uncomfortable. I'm not a physician. I just didn't feel ready. Like, right? But my frozens, they did freeze them, but my frozens never survived the thaw.
right. But 20 something years ago, we were using a technology called slow freeze, which had, maybe 50 to 75%, 65% survivability of the thaw. So
Yeah,
fortunately, we've all adopted to vitrification probably in the last 15 years or
yeah,
so,
yeah.
so that greater than 90%, 95% of embryos that are frozen, that are good quality, survive the thaw and, thank God, do well.
Yeah, you're right. Because well, I tell people it was a wing and a prayer. I think I had a 30% chance of getting pregnant with IV when I was doing it. It was really low. But my first transfer with my surrogate worked. They put in about 5 million embryos. But again, day 3, fresh. embryos didn't survive the thaw, right? It was just a whole different time, when we were doing them. But have you seen, right, it was. I tell people, I'm like, you have no idea. I call it the dark ages. I was breaking glass vials and mixing pergonal, I was like a little chemist.
Every injection was intramuscular back then.
Everyone was a big needle, right? Yeah. Everyone. It was fine. It was all good. I would have done like a gazillion of them.
Everybody would have done anything, and they still want to do anything.
They
And that's
do.
what makes it so difficult when we don't have success.
Yeah. So are you seeing, because I'm on all the Facebook groups, are you seeing a difference between a first and a second transfer? Like there's more repeat transfers. I know there's one embryo now, so that's been the biggest change, 1 to 2 embryos. That's been the biggest change in the
Here's
past.
something that I think we're a little different, and that is I like to individualize care for every single patient.
Good.
So there are situations where, from the get-go, from the start, they're going to do better placing 2 embryos rather than one. So, for example, even if an embryo is genetically normal from a 42-year-old, that 42-year-old's embryo, even though genetically normal, has a lower implantation rate and therefore a lower chance of pregnancy than if it's from an egg donor or from a woman under 35.
That
So,
makes sense.
I mean, every single case needs to be individualized. But yes, the overwhelming majority of transfers that we are doing now are indeed single embryo transfers.
Yeah.
Now, I was the very first ever to help a male-male couple using a donor and a surrogate. So this case was back in 1997. And we actually, I'm sure you're familiar with the case, we had to
Yeah.
change the laws, and you were involved in all of these kinds of things.
Yeah.
And since then, I've done over 2,000 male-male couples from all over the world. That particular unique patient population really frequently wants to have 2 embryos placed, one from each gentleman.
They do.
And I really think that if the surrogate is educated and the intended parents are educated with the risks of premature delivery and premature, developmental things, that they have the right to choose to place 2 embryos if that's what they so desire.
Yeah.
And so I think one of the few docs that are still willing to do that. And look, I've had 4 outcomes placing 2 embryos for people. God
Yeah.
forbid they don't get pregnant. They get pregnant with 1, they get pregnant with 2,
Yeah.
or God forbid they get pregnant with 3, which is 1 embryo splits, becomes identical twins, and the other embryo implants.
We had that. It was a couple who had gone to Europe. It was their last embryos. You said this is the bottom of the barrel. I think they were like grade C. I mean, really, they were like nobody. I mean, I think they were just desperate. And then you're right. They got triplets. They got a set of identicals, an individual, a singleton. But best outcome, they were in 3 separate sacs and 3 separate placentas. As the father said, 3 restaurants. He was a foodie. So yeah, 3 little restaurants. And you know what? That surrogate, oh my gosh, I want to say she went 36 weeks. I mean,
So, I
she
mean,
was amazing.
we're humbled a lot because there are women that do great and do that. And early in my career, I had a lady who, had triplets, and she convinced the high risk team to be able to go through labor, and she delivered triplets from below, which probably is unheard of now. But
Yeah. Especially in
so
California.
every situation is different, and I think it's very important to individualize everybody's care. And so a couple of things for your parents who are looking for centers and looking for agencies and attorneys. I mean, you're an attorney, but you're an attorney who specializes in reproductive medicine and health.
Yeah.
I have attorneys that are buddies who are, they do contracts all the time for real estate. This is a whole different type
Whole
of
different.
area. And so you wouldn't go to a gynecologist because you have chest pain. You're going to go to a cardiologist. So
I tell people this all the time.
I understand it. But I mean, they say, oh, I know contracts. I can write a contract like that. So, I think that what's really important is when you start to select the people you're involved in, you want to make sure that they have experience, that this is what they focus on and this is what they do day in and day out. So my entire practice is focused on reproductive medicine, focused on, probably 75 to 80% of the patients I take care of are third-party reproduction. So either an egg donor involved or a surrogate.
Right.
And that has been my area of expertise and my area that I have taken care of patients for the whole 28 years I've been in private practice alone. In fact, my very
You've done a
first
lot of
two
third party.
patients were surrogates. And, back in the day, it was word of mouth because who knows how to do a surrogate? It's very, there weren't very many of us. And then it's experience in terms of what we're looking for. And my entire team understands that this is the intended couple, but the intended couple is not caring and what the ramifications are. And then in 2005, the United States federal government and FDA changed all the laws and regulations with regards to tissues going from one person to a non-intimate partner. And that kind of set everything upside down initially.
My God, do you remember that? I remember that.
Yes. So we had to, change all our consents and change all the forms that we use. And I mean, we've been inspected probably 8-10 times when, FDA shows up with the badge and says, we want to look at all your charts, which is always a very exciting day. And sometimes they stay 2, 3, 4 days and they have the right to look at everything and look at your laboratory. And, so, I mean, we're very, very detail oriented. I'm intimately involved in every single case. I still write all the protocols. I still do all the ultrasounds. I still do all the procedures. We have a modest sized practice, so that may not work for everybody, but a lot of the patients that I take care of are very happy that that's how we do it.
I have to say that I think people are going back to more of that. They really want that because maybe it's because, like we talked about and joked that, there's like, an app for this and an app for that. And if you don't get back, and I think people want that kind of connection. I know you come out and you greet everybody, the patients, whether it's a surrogate, a donor, or an intended parent. They're like, oh, the doctor's going to walk me back. Yes, the doctor's going to walk you back. Yeah.
I do that for everybody's first experience with us because, look, I try and treat our patients like the way I want my adult wife, my adult children to be treated.
Exactly.
And I mean, so, there's certain things that I tell our staff, and that is you can't teach care. Either you care about your patients or you don't. And there is no, gray area, and it's not something you can fake. Either you like what you do or you don't. And children are the best at discovering and telling it to you straight as it is. How come you're looking at your phone and not helping me with my homework or whatever the heck it is?
Can't do your math homework.
I can't do it now, we got to hire a tutor, but
oh my
still.
gosh, that math homework.
But so I think that I've had many patients from bigger centers come here and make the comment that they never saw their doctor except for the day of the procedure, that they waited weeks or months to get a phone call back about results or, what's the next approach. And I'm not saying we're perfect. I'm just saying we're different. But I mean, that would not fly in my practice. And I wouldn't tolerate that as a patient. My wife certainly wouldn't tolerate that as a patient. And I wouldn't want that for my children or my grandchildren.
No. So when you're looking at a double uterine transfer, I know my surrogate, I tell people this, my clients too, that she went nearly 38 weeks and delivered vaginally, which, right? I mean, twins.
Unheard of, phenomenal.
Unheard of. She was amazing. But she's taller than I am, right? Like, and I've read that, not only height, but then I did talk to a surrogate who was teeny tiny itty bitty and went like, she had her own twins naturally. She goes, oh no, I was fine. I'm like, how tall are you? I think she was like 5'2".
It's really hard to quantify. And I also have, I had a single male who wanted twins and found the largest person I had ever met as a surrogate who was about 6'5", and appropriate weight, but was the tallest woman I ever met. And she got pregnant on the first attempt, and she carried full-term twins. I think height does play a role. I think that, body habitus plays a role. I mean, I'm very strict with regards to body mass index because I believe very clearly, and the data suggests this, that a woman who starts heavy will have a much higher risk pregnancy with regards to risk of hypertension, diabetes, decreased blood flow across the placenta through to the fetus that could potentially force the obstetricians to do a delivery to help for the overall health of the surrogate or the woman who's carrying. So
That makes sense.
I think these things are important. I think the discussion of, as much as high as 50% premature rate. Now, there's a huge difference between somebody delivering at, 24 to 26 weeks versus somebody delivering at 34 or 35 weeks. So
Correct.
a lot of
Yeah.
it has to do with education. A lot of it has to do with, somebody who's very motivated to do well. And a lot of it has to do with the OB team being very attuned to the fact that, hey, this woman's carrying twins, and twins is a lot different than just a singleton. It's not like, oh, I'm doing two babies at the same time.
Right. Yeah. 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 I am seeing a lot of talk about BMI. Like that was not something
Right? In the
that,
old days, it wasn't something we focused so much on.
no, like there are surrogates that did an
Companies,
amazing job that would
right,
never pass today.
right, right.
Never. Nope. And another thing that I'm hearing is that preeclampsia comes from the male side. Whoever contributed the sperm, if they had a history in their family, I don't know if it's true, but I'm hearing a lot of chatter about that it's not necessarily.
I don't know if that's truly accurate. Preeclampsia is much more common in certain ethnic groups. It is
Oh,
much more common in the first pregnancy. So fortunately, our surrogates, by definition, are not going through their first pregnancy. So we see a lot less of that. It's a higher risk if somebody has hypertension in general. And again, most of the surrogates that we work with are indeed young, healthy women that
right.
are very generous to be able to try and help and carry for another couple.
It's an amazing thing. I tell people it is no joke. These women are putting their health and their life, sorry, I'm the attorney, it's in the contract, I'll read it, at risk. I mean, when a physician told me, because I was very sad, I needed a surrogate, I finally got one, and he's like, Stephanie, being pregnant is hard on your body. And of course, nobody tells us women anything. They don't tell us what's going to happen when we start our period. They don't tell us what it's like to carry and deliver a baby. And they don't talk about menopause. Nothing. And I looked at him, I went, what are you talking about? He's like, Stephanie, all your organs shift and get moved up. I was like, oh my God. Like, really? I'm like, holy heck. It is like
Um,
no joke.
a
Yeah.
non-pregnant uterus, for frame of reference, is about 50 grams. A full-term uterus is about a kilogram. So what's amazing about the uterus is it's the only organ that can expand, designed to expand, to carry a
Yeah.
child, and then go back down to normal size and be able to do it again.
And
So
again,
there's no other organ in the body that can do that.
no. But to
No
do
other.
that, things have to move.
Oh, of course, no question. And what's also amazing is that, you know, um, unfortunately, not every uterus works.
Correct. Mine did not. Yeah. Which is why there's still some surrogates today who reach out and say, I want to be a surrogate. And they're like, if you had a baby, and they're like, no. And I'm like, look, people would have looked at me, oh, she's in shape. She could carry a baby. I'm like, you don't know unless you do it. You
Right.
don't know if you can get pregnant. Just because I appear to have all the parts doesn't mean I can do it. And I couldn't do it. Right. So. But it is no joke. I tell these people, listen, it's a serious, and the fact that these women just say, yeah, I can do this, and they do it well. I mean, yes, they get to the end and they're big and they're bloated, and if it's, August, they're cranky. I mean, I would be too, right? I would be too. at the end of the day. You know, it's interesting what you say about preeclampsia because my surrogate had it with her first baby. I want to say she didn't have it with her second, but she got it with mine. I don't know if she had it with her last. She ended up,
May have gotten it with yours because she was carrying twins, which is a higher risk for preeclampsia than a
correct.
singleton.
Yeah, correct. Yeah. Yeah, she got it and they just said, okay, we're going to induce. Like, that's it. You're 37 and a half weeks. We're going to
Right,
induce. And they
right,
did. Yeah, they
right.
did. It was like watching paint dry, though. Seriously. She was on the Pitocin drip all day. Finally, they upped it. And then I know people are going to hate this. She was in hard labor for like 2 hours with twins. Like, it was insane. She was meant to have a gazillion children, is all I have to say, for sure.
Terrific.
All right, so I think this has been a great talk. Is there anything you'd want to say to any of the, intended
First of all,
parents?
I appreciate you speaking with me. And again, I think it's very important, again, no matter who they choose,
Yeah,
agency, physician, attorney team, psych team, they got to be with people who have a lot of experience just in this area. And I mean, people are not stupid, so they know if you've done it or not, if you have an understanding of what's going on, because everybody I talk to has spoken to two or three other people at least by the
yep,
time they're speaking to me, as and so I guess, what makes us different is I'm very intimately involved. I have a lot of experience. I still enjoy what I do. And we've been very fortunate to have a lot of successful people patients that, you know, make that commentary and recommend that their friends come and see us, which has kept my practice alive for almost 30 years.
I have to say I can attest to that. And there's something you said to me a long time ago, I will never forget. You said, Stephanie, you can't teach nice. And
That's
I
true too.
I said, oh my gosh, he's so right. Like when I was at the conference, a bunch of agencies, people in our industry, you could tell the people that like felt it in their heart, like felt like I am doing this because I want to see somebody have the baby that they've always dreamed of, the family they've always dreamed of. Yeah, and you can't teach that. No.
Right?
Yep. All right. Well, on that note, thank you, Dr. Smotrich. I call him David, but you can call him Doctor.